Hello, everyone, and welcome to this Disability Competent Care, or DCC, on-demand video presentation on the topic of care coordination, brought to you by the Resources for Integrated Care. This brief presentation will present key information and content on the topic of DCC care coordination from several sources, including previous webinars, tools, and resources produced by Resources for Integrated Care, or RIC, in collaboration with DCC subject matter experts. On the slide here, you will see that there are links to the resources that supported the development of this presentation. Those are available for viewing and download on the RIC website. In order to access the links and resources on these slides, please download the slide presentation from the Resources for Integrated Care website at www.resourcesforintegratedcare.com. The target audience for this presentation is health plans and providers who serve individuals that are dually eligible for Medicare and Medicaid to effectively address issues regarding coordinating care for individuals with disabilities. This presentation will focus on the key elements of care coordination, including the role of interdisciplinary teams and strategies to improve care coordination. This resource is supported through the Medicare and Medicaid Coordination Office, or MMCO, in the Centers for Medicare and Medicaid Services to help individuals enrolled in both Medicare and Medicaid programs have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to dually eligible individuals, MMCO develops technical assistance and actionable tools based on successful innovations and care models, such as this resource. To learn more about current efforts and resources, visit Resources for Integrated Care at www.resourcesforintegratedcare.com. The following presentation will cover a few important aspects to DCC care coordination. The learning objectives that will be covered in this resource include reviewing the key elements of care coordination for individuals with disabilities, sharing strategies to improve care coordination, and describing the role of interdisciplinary teams in coordinating care. The presentation will be divided up into 6 sections: background on the population at hand, critical areas of care coordination for disability competent care, strategies for effective care coordination for individuals living with disabilities, the interdisciplinary team, or IDT, communication among the members of the IDT, including the participant, and tailoring services to meet the individual's specific needs. First, let's get started with providing a brief background on health disparities and social factors that can lead to poor health outcomes for people with disabilities. As you may be aware, research shows that people living with disabilities face significant health disparities. This is due to a variety of barriers, including difficulties and delays in accessing necessary health care. For example, people living with disabilities often experience worse outcomes, are less likely to receive recommended care, and may not receive the comprehensive preventative care that they need. In addition, people with disabilities have a disproportionately higher incidence of conditions such as high blood pressure and hyperlipidemia. The impact of these disparities ultimately results in poor health outcomes, as well as secondary and chronic conditions. To improve health outcomes, it is critical to address the gaps in care coordination that often disrupt continuity of care and lead to fragmentation of care for this population. A wide range of social factors can lead to poor health outcomes for people with disabilities. Many people with disabilities rely on programs such as Medicare and Medicaid for their health coverage. These programs are undergoing extensive redesign, particularly moving from fee-for-service to value-based models. As a result, payers are becoming more focused on outcome measures like cancer screenings and diabetes management. This change in focus has downstream effects on the healthcare system and care delivery. Effective disability competent care considers the various factors and barriers that may be present for the participant. Employing a comprehensive and person-centered approach to address these barriers can go a long way to improve performance measures and ultimately outcomes for people with disabilities. Next, let's cover some critical areas of care coordination for individuals with disabilities. There are 4 critical areas of care coordination. These include planning care transitions, managing transitions, managing medications, and planning advanced directives. This slide provides a brief overview of each area, and on the subsequent slides, we will dive deeper into each area. First, care transitions planning involves developing a person-centered and individualized transition plan for the participant. Managing transitions involves developing an appropriate course of action to carry out the transition plan and addressing all aspects of the transition process. Managing medications involves the use of a central health record to facilitate medication management and reconciliation. And lastly, advanced directives planning involves planning and discussions of end-of-life care with respect and sensitivity. The first critical area of care coordination is care transitions planning. A care transition typically refers to a move into or out of a care setting, for example, moving out of a nursing facility and into one's home. The initial planning step involves developing a transition plan using a person-centered approach and aligning with the participant's expressed desires and needs. Ideally, the transition plan addresses all aspects of the care transition process to ensure continuity of care and to meet the health and safety needs of the participant. Transitions have a far broader scope when working with people with disabilities and can involve changes in care settings, providers or medications, as well as financial, housing, legal, employment, and other issues that may affect the participant's ability to live independently. The second critical area of care coordination is managing care transitions, which involves an important step of developing an appropriate course of action to carry out the transition plan that addresses all aspects of the transition process, which includes accounting for significant changes or issues that may arise. Any transition represents an opportunity for potential errors to occur, which means that the interdisciplinary team, or IDT, should be especially alert to monitor the progress of the transition and to identify opportunities to take action to ensure the health and safety of the participant. For example, a person with a physical disability who is transitioning from a facility to home may need accessibility modifications in their home, like an installation of a grab bar or a shower seat, in order to prevent an accident and rehospitalization from occurring. A member of the IDT can be designated to help ensure the successful completion of the transition process and to provide appropriate follow-up. It is essential that the IDT understand the reasons for the transition and to coordinate the follow-up appointments and medication management. An example of a best practice is the IDT using protocols or checklists to assist in managing transitions. The third critical area of care coordination is managing medications. Given the varying health needs of people living with disabilities, participants may have multiple providers prescribing medications. A change in one medication by a provider could be missed by another provider, which can result in medication duplications and interactions. Using a central health record can facilitate medication management and reconciliation, and is important to enhance participant safety, reduce the possibility of adverse drug events, and improve a participant's medication adherence. It is necessary to take the participant's functional status into consideration when prescribing medications, and any functional limitations should be documented in the central health record. For example, if a participant has limitations with fine motor movement, having the participant inject himself or herself with a medication may not be easy for him or her to do. It is also necessary to take into consideration the participant's health literacy, cultural beliefs, and any potential communication barriers when prescribing medications, and document these in the central health record. For example, a participant's health literacy affects the degree to which the participant can understand health and medication information, and this will in turn affect how the participant interprets prescription labels and dosing instructions or measures medications. An example of a communication barrier is when a provider does not effectively communicate to a participant the importance of finishing all of a medication that has been prescribed, and the participant decides to stop taking the medication too soon, which can have significant health consequences. The fourth critical area of care coordination is advanced directives planning. Person-centered advanced directives planning can help people identify their end-of-life wishes, such as who they would like to have present, how they would like to be made comfortable, what kinds of treatment they wish to have or not have, and what religious or spiritual support they want. It is important to have a trusting relationship with the participant, as well as take into account any cultural or religious preferences or potential communication barriers when having planning conversations. Having these discussions with participants in care planning meetings rather than when the participant is in crisis will allow them to make informed, well-thought-out decisions. During emergencies and other crises, participants may feel pressured to make decisions they are not fully prepared to make. Covering advanced directive issues during care plan meetings also presents the opportunity to review plans on a regular basis and adjust as circumstances change. Planning involves deliberate, ongoing communication that emphasizes listening, learning, understanding, and acting on what is important to support the participant. Advanced directives should be reviewed annually and amended as appropriate, with copies provided to key providers. For care coordination for participants living with disabilities to be effective, there are some fundamental strategies providers can implement. At this point, we're going to touch on just a few of these. First, developing and maintaining a trusting relationship with the participant is a fundamental strategy for effective care coordination. Like any relationship, communication is key. Direct communication with the participant is vital, as well as taking the time to understand and assess what is important to the participant. Exploring how capable and willing the participant is in engaging in his or her own care will enhance the participant's trust and strengthen the relationship with the participant. It is essential to focus on the participant's goals and preferences and to employ a person-centered approach in the development of a person-centered and individualized care plan. When the participant's preferences are taken into consideration, care coordination activities and outcomes are ultimately more successful. Engage in direct communication with the participant's IDT, with the participant's consent. The IDT may include family members, home care workers, physicians, and behavioral health specialists, to name a few. As much as possible, include the participant in those conversations and communications with the IDT. The IDT should work together to orchestrate the necessary arrangements to meet the specific needs of participants, as described in the participant's person-centered care plan. These may include assisting with making medical appointments or helping the participant with the Medicaid eligibility process. On the slide, there is a link that you can access a first-person narrative from an individual living with a disability, Camille's story. This story illustrates the importance of an individualized and person-centered approach to care coordination. For Camille, this meant that her care team listened to what was important to her, took into account her expressed needs and preferences, and supported her in achieving her goals. You can visit the Resources for Integrated Care website to access similar resources. Now, we will define and discuss the interdisciplinary team, a core component for delivering comprehensive care coordination for dually eligible individuals with disabilities. In the DCC model, care coordination involves the implementation, oversight, evaluation, and refinement of the participant's care. The work of care coordination begins once the participant's assessment is completed and the individualized care plan, or ICP, is developed with the participant, taking into account the expressed desires, goals, and preferences of the participant. Ongoing oversight and review of the ICP with the participant is needed to ensure plans are effective and being followed, preventative strategies are in place, and revisions are made based on the participant's expressed and evolving needs. Care coordination is then facilitated by an interdisciplinary team, or IDT. Within the IDT, each member of the team, including the participant, brings his or her unique competencies to inform a comprehensive approach to the participant's care. The IDT is designed with the purpose of supporting the health and well-being of participants in a collaborative, structured, and person-centered way. An IDT brings together providers from various specialties with diverse knowledge to respond to the participant's physical and clinical needs, while also considering the participant's emotional, social, intellectual, and spiritual needs. It is imperative that the IDT members understand and apply the concepts of disability competent care. Primary considerations when assembling the members of an IDT together, beyond the participant's medical needs, include the participant's primary language, cultural beliefs, and preferences and desires. To ensure that participants living with disabilities receive adequate care to meet their varying health and safety needs, providers and IDT members should have training and familiarity in providing disability competent care and experience working with persons living with disabilities. A main component of an effective IDT is designating a lead coordinator. This lead coordinator is responsible for the oversight of the team, as well as being accountable for the individualized care plan. The lead coordinator serves as the key communicator between the IDT members, including the participant. There are several resources available that providers and various professionals can utilize to learn more about and improve the care and services they provide to individuals living with disabilities. These resources will be available at the end of this presentation. We will now discuss another critical element of delivering effective care coordination for the dually eligible population with disabilities, IDT communication. Communication is a cornerstone of care coordination. This is true of communicating directly with the participant themselves, but also communicating among the IDT and ensuring that the participant is included in those conversations as well. Establishing effective practices and channels of communication among IDT members, including the participant, is important for ensuring continuous and timely care. Participants should know how and when to reach out to other IDT members for needed support. Actively listening to the participant's perspective goes a long way towards strengthening the relationships within the IDT. This includes hearing their perspective and acting on their desires or wishes for their care. Additionally, it is critical to understand the participant's own perspective about his or her disability and functioning. This can help determine the ability for the participant to engage in his or her own care planning and where participant education may be needed to enable that engagement. Similarly, it is important to establish a protocol for communication among IDT members. Sudden changes can happen. Therefore, it is imperative that teams know how to respond accordingly. Designating a lead who is responsible for being the primary contact to the participant can ensure that the needs and preferences of the participant are being met and that the ICP is being followed appropriately. As such, different points of contact may also be established for external providers that the participant uses. Teams should meet on a regular basis to discuss any pertinent updates and issues that need to be addressed, including new assessments and reassessment reviews. Finally, we will address the importance of tailoring services for effective care coordination and planning. Decisions made about a participant's care and services should acknowledge that the participant is the primary expert of his or her own life and care needs. Therefore, it is important to ensure that care planning and service decisions take into account the participant's preferences, goals, and needs. Decisions should be made within the framework of respect for the person's dignity of risk. Dignity of risk refers to the participant's right to identify his or her needs and make informed choices to experience life and take advantage of opportunities for learning, developing competencies and independence, even when healthcare professionals believe these choices endanger the participant's health or longevity. The participant's services and care should be updated or modified over time to meet the participant's changing needs and preferences. The next two slides list additional resources and the sources cited in this presentation. As a reminder, to access the links and resources on these slides, please download the slide presentation from the Resources for Integrated Care website at www.resourcesforintegratedcare.com. This slide lists several resources for more information on improving and employing comprehensive care coordination efforts for participants with disabilities. These resources can be accessed on the Resources for Integrated Care website. These resources include personal narratives, as well as tip sheets and templates that providers and other professionals can utilize to better coordinate care for participants with disabilities. On this slide, you will see the sources cited in this presentation. This concludes our presentation on DCC care coordination. Thank you for taking the time to listen to this presentation. If you have any questions, please feel free to email us at rick@lewin.com. That is RIC@LEWIN.com. Lastly, we want to hear from you, so we would love for you to send us your feedback. As always, your input is essential in developing new trainings and resources on disability competent care. Send us your suggestions via rick@lewin.com on how best to target future DCC webinars, trainings, and other resources to healthcare providers and plans involved in all levels of the healthcare delivery process. We also welcome any feedback on this resource and ideas for other topics to explore on future DCC resources. We hope this video was useful, and thank you again for joining us.